Of course, there are always situations where you may meet with a frontline staff member who may not really want to engage with you. And you will have to find someone else on the unit who kind of can speak for the unit, who's a little more approachable. And I think as humans in healthcare, we all can tell just by nonverbal cues who is really approachable or not.
Infection stops where information starts. Welcome to the Transmission Control Podcast, where knowledge is your strongest defense. Broadcasting from the front lines of healthcare, we dive into the strategies, science, and stories shaping infection prevention today. Each episode, we connect you with experts on real-world insights to help you stop the spread of healthcare-associated infections, protect patients, and strengthen your practices as an infection prevention and public health expert. When the right information reaches the right people, lives are saved.
Hello and welcome to another episode of the Transmission Control Podcast. My name is Garrett Hollenbeek. I'm joined with Jill Holdsworth today. And our guest today is Carole Kamangu, CEO of Dumontel Healthcare Consulting and an infection prevention consultant. Carole brings to us a huge wealth of both frontline experience as an RN and also a wide range of experience in epidemiology, public health, and infection prevention. Today we dive into building a good rapport and foundational dynamic with frontline nursing. We'll be back after a brief word from our sponsors.
Brought to you from the studios of Healthcare HQ, let's get into it. This is Transmission Control.
Hello and welcome to the Transmission Control Podcast. My name is Garrett Hollenbeek, Editor-in-Chief for Transmission Control, and I'm joined today with our host, Jill Holdsworth. How are you, Jill?
Hey, I'm doing great. How are you, Garrett?
I'm good. And today we have a pretty exceptional guest on today. And I know a lot of people out there in the IP world know of Carole and have interacted with her, but Carole Kamangu is just a powerhouse in the IP space. And today we're going to be getting into a topic that I know is really kind of intimidating for new IPs in orientation, and that's building good dynamics with frontline nursing staff. So Carole, welcome. Thanks for being on the podcast today.
Thanks for having me. It's always great to see you, Garrett.
Yeah. So Carole, for the 5 people out there that don't know you, tell us a little bit about yourself.
Yeah, so I'm Carole Kamangu. Well, I go by Carole W Kamangu because I'm having a hard time dropping my maiden name. So I'm a trained nurse, also an epidemiologist, and I love wearing that epidemiologist hat because it's just so fascinating with outbreaks. I enjoy investigating and just using critical thinking. But I've been in this field in healthcare I'm going on, this year will be 15 years. And I've been enjoying every moment of it. Most of my focus is really public health and infection prevention. And that's been over 11 years by now. And I just love this field.
I love it. And in addition to your work, you've worked in a lot of different settings in healthcare and in both your public health with your public health hat on and then your RN hat on. So what are some of those spaces you've worked in and impacted in your career?
Working in the hospital, I've worked at the bedside as a medical surgical nurse, a neuroscience nurse, telemetry nurse. And when I went into the public health space, I started in communicable disease. So I was an investigator. And I was also a backup for the TB program, doing case management and investigations and site visits. When I went back to the hospital to really wear that IP hat, I was already doing IPC for 5 years in public health, but then decided to go do that in the hospital, work with every department. I was the point person for the OR for behavioral health, for some ICU units, medical, surgical, and many of the clinics as well in the health system that I was serving. So I've been to pretty much several areas, and I'm pretty sure I'm forgetting some of them.
Well, you've been just about everywhere, it seems, Carole.
Yes, I have. Yes.
Now, when you were working as a frontline nurse, whether in ICU or on a neuro floor, what was your interaction with IP like? Did you see IP very often? Was it a positive interaction?
Yeah, that's a great question. So in my career at the bedside as a nurse, I didn't even know this field existed. I didn't know what an IP was. I didn't know that infection control was a thing. I started finding out when I was going through my MPH program and working for a different hospital. As I was orienting for that hospital, some guy came and said, I'm with infection control. And started talking about, this fascinating organisms. And he was talking a lot about MRSA at the time. And I said, whoa, this sounds like the kind of things I'm into. So what is he talking about? So yes, that was the first time I heard about infection control.
I think that's a pretty common answer these days that, I just fell into this field or I had no idea it existed. And then all of a sudden I just fell in love with it. So it's so interesting to find out how people were working in hospitals and totally oblivious to IP. It seems crazy to us now that we're working in it. Like, I can't believe you didn't know your IP, but it happens all the time.
It really does. It makes you think, like, what staff members have I never interacted with? And I always think about third shift because years and years ago, I worked as a STNA or like a PCA, but here in Ohio, it's, STNA. And, you're working third shift. You're not even thinking about IP rounding. Obviously, you do your hand hygiene stuff, but that's a whole we could talk about that a lot of like third shift is a missed opportunity for IPs to be around.
Oh, for sure. We did hand hygiene, isolation. There's all these like YouTube funnies about how like, I work the night shift because no management's around. Joint Commission doesn't come to the night shift. That's why I work nights.
Now, with your experience in both as a bedside nurse and then in infection prevention, what are some of the hesitations, especially new IPs may have, about interacting with bedside nurses?
Yes, that's a great question. And I have to be honest, as a nurse myself, I have an unfair advantage. But I also know how nurses think because I am a nurse. We are well trained and we know what we're doing. So even myself as a nurse, I was very intimidated. I spent most of my career at the bedside, not in the ICU. So I was very nervous when I had to go talk to ICU nurses because they know their stuff. They're really good.
It's a different breed.
It is a different breed. They're really on point, very independent, very knowledgeable. Yeah, my experience is that I know everyone gets very intimidated, and it's totally normal.
What are some do's and don'ts maybe that IPs, when they approach or speak with bedside staff, we'll start with some do's. What are some good, helpful tips that we can have?
Yes, what I would say, and I usually say that even to new IPs that I mentor and coach, infection prevention is a relationship business. So you're not here to impose your policies, your ideas on anyone. So my tips are always when you go and meet nurses at the front line, remember that you're talking to humans. So start with a relationship, build a relationship. And for them to start trusting you, they have to know who you are. Just make sure that you're really creating genuine relationships, start knowing your organization. And every department is different. Every unit, every clinic is different. So when you go into an area, let's say you go to the burn unit, they're going to have a different culture than if you go to the ICU. So get to know the culture, find that person that okay, this person will be easy to talk to, find your point person, be kind, be polite, introduce yourself, and just remember that this is a conversation with a human, so just be natural. Because I've seen in some situations where the IP, because your role is, I'm here to protect everyone. They just come to impose themselves right away. Okay, I'm from IPC and I'm coming to tell you this. That's not the way to go. because the energy you bring out is the energy you're getting back. If you're coming forcefully, you're getting a backlash and you know it's not going to work. So I always say that, remember that it's a human to human relationship. We have to be decent human beings. Think about that before you even step foot into that department.
So Carole, this season is all about the new IP and orientation and onboarding. And I know a lot of new IPs are very hesitant, kind of timid when they're going onto the units for the first time. It's easy to just go and do a quick round on the unit, look at isolation signs and be like, see ya, I did my rounds today. But how do you tell new IPs to actually start up the conversations? Like, what do you actually say? Like, you say, hi, I'm Jill and I'm with IP, but then what? Do you just say like, so what's up? What, how do you actually start the conversation? Because it's harder than just saying, tell them who you are and what you do. But then what?
Yeah. Yes. And I always say it's an art in itself. We all have different personalities. Some of us it's just easy for us to talk to other people, but I totally understand that, especially if you're an introvert, it may come off very awkward to start that conversation. So that's a great question. What I always say is, if it feels really awkward to start a conversation, just remember you're talking to a human being just like you. Think about someone that you like, that you're really comfortable with, and start that conversation that way. Not being disrespectful. You really come politely, smile, and I always say, please smile. Please smile and introduce yourself. And if it feels very unnatural to start that conversation, we have communication frameworks that we can use in healthcare. Nurses and clinicians in general use the AIDET framework. The framework AIDET in healthcare, we use it usually to just guide our conversations with patients, but it's really easy to use it in this context as well. So A is for acknowledge, I is for introduce, D is for duration, E is for explanation, and T is for thank you. So in this example, let's say you're going to this floor, you've never been there, and you're going to round on this floor. You're not going directly to the floor and start rounding, because first of all, especially if you're a new IP, you're a stranger. So they'll look at you with weird eyes. Some facilities may report you, and I say that because it's been my experience learning in public health, about the Hawthorne effect and learning about doing your observation as a secret shopper. I've made this mistake myself in my career, going into a unit I had never been to and started observing for hand hygiene, and I had the worst looks and was reported to my manager by 5 people. And my manager had to talk to me. So in this example, you're going to round, find the charge nurse or whoever is at the desk. If it's not the charge nurse, is the program assistant, they can talk to you, ask them to speak with the charge nurse. So as you come, you start, hi, I'm Carole. I'm a new IP. I've been in this facility for 3 months. You haven't met me yet, but I'm here to just get to know you guys. And today I'm kind of coming here just to see how things are going. You don't say I'm coming to round, because that's intimidating. I'm coming to see how things are going here. I'd love to go around and just see what's going on, if you need my help, if you have any questions. And also, so I just get to know how you guys work here. It's going to take me about 5 to 10 minutes, maybe 30, depending on, how big the unit is. And then I'll come back to you. And if I have questions, I'll ask you. If I notice something that needs to be maybe changed, we can discuss together and see what we can do next. And then they'll tell you, oh, okay, no problem. In general, they'll say, oh, yeah, that's fine. Because you came very kindly with a big smile and said who you are. Then they'll say thank you, and you're going round. Okay, I have this questions, or I noticed this. Let's talk about it. Then you're able to start a new relationship that way. And of course, there are always situations where you may meet with a frontline staff member who may not really want to engage with you. And you will have to find someone else on the unit who kind of can speak for the unit, who's a little more approachable. And I think as humans in healthcare, we all can tell just by nonverbal cues who is really approachable or not.
That is true. I love that framework of the AIDET kind of way of approaching our coworkers in healthcare. And I think that talent of like kind of reading the room. If you go up to a nurse and they're elbow deep changing a patient or trying to, deal with an emergency, that's not the time to talk about, your device audit. And I know for myself, because I'm not coming from an RN background, when I started as an IP, I would say, hey, can you just show me, I've got the bundle compliance here. Can you walk me through it so that I learn and come into the room with me? And that became kind of standard practice for our facility. And it just started out of my own ignorance. But I think admitting that ignorance then allowed them to say like, all right, I'm going to take you under my wing a little bit and show you what you don't know, because there's a ton that I don't know.
That's absolutely correct. I like the sentence that one of my old bosses had mentioned before. She said, you're going to their turf. They're not coming to your turf. You're going to their turf. So be polite, be kind. It's like you're going to someone's house. You don't just open the door. You knock and ask, can I come in? So that's the same concept.
Yeah, that's really important. It's like their home. Their unit is their home. And as much as we want to say we're part of their team, we're an outsider, and to what Garrett was saying, like what is the appropriate time to say things. I think it's also important that new IPs really think about too, when do I approach somebody to say, hey, do you know you're supposed to have on a gown in there, or you didn't wash your hands? And I've heard many accounts of situations in the past where they've done it in front of the patient or in front of other coworkers. And again, you really have to know when and when not to say certain things, because you'll make a lot of enemies real quick if you start to tell them things they're doing wrong and other people are around, or especially in front of the patient.
I totally agree. Yes, especially, and I'm so glad you brought that up. In front of the patient is not the place. In front of coworkers out loud is not the place either. If you want to do it in front of coworkers because that's the only moment, the only opportunity, make sure you take them aside, because nobody wants to be outed like that. It just feels disrespectful, and yes.
That's a good point. I kind of want to highlight that too, because patients don't know what infection prevention necessarily does or why they're there anyway. I've had, and again, I'll tell on myself here, I used to say, Garrett with infection control. And that makes people freeze up, even patients, and think like, uh-oh, you're about to tell me I'm like supposed to be in quarantine, or I've got some weird disease that nobody's ever heard of. So say that you're from infection prevention. That's why we say prevention. But how do we do our job and round on patients and devices while not frightening patients, not, disrespecting their privacy, and making it a comfortable environment for them?
Yes, that's a great question. And this is where this AIDET framework also comes back. It's very useful when you're in the patient environment, the patient room. But when you're coming in there and you need to be there, and this is your question is really about speaking to the patient directly or the staff member in the patient's room?
I think both, because both have some kind of challenges to it.
Yes, when you get into the patient room, use the same framework. You first of all have to knock, because that's their room. They're paying for that room at that time. So that's their room. You can't get in there without telling them anything. They have to know why you're in there. And you start by, hi, I'm Carole. I'm from infection control. Well, infection prevention is actually best, as you said.
Sure.
I'm from infection prevention, and my role is really to make sure that everyone is safe, your nurse and yourself, that we're not spreading any germs in here. So I'm just making sure that everything that's happening here is really good. So I'm just going to be here maybe for 5 minutes, just ask you a few questions just to make sure that everything is on point. And you start explaining, let's say if they've been diagnosed with C. diff, you start explaining maybe what the issue is, why they need to be isolated, how it protects their family, protects staff, and you also make sure that we can really focus on their care, really making sure that they understand it's for their safety and everyone's safety, and that we're not here to make them uncomfortable. But that framework just is really helpful to have. I would recommend, if you don't know it by heart, practice. Maybe if you can have it laminated and add it to your badge, so you can maybe refer to it before you get into the patient's room, that would be great practice as well. And if you need to speak to the staff member there in the patient's room, as you mentioned, Garrett, if they're doing a dressings change, You may be there to observe. You need to explain to everyone you're there just to observe. But if you want to make any recommendations, I would say just wait until they're done. When they come out, you may wait for them at the nurse's station, and then you can speak to the staff member outside of the patient's room.
I wanted to tell you one thing that we have added on to our AIDET is an H at the end. So we pronounce it AIDET. and the H stands for hand hygiene. So that when we're going into the patient room and when we're done, we say thank you. And it's really meant to also verbalize, like, I'm just going to wash my hands here before I leave, because then if they don't see you washing your hands, you're telling them, because sometimes it's the perception, that perception of, was my room cleaned or not? I didn't see the person cleaning it, so it wasn't done. So maybe they don't see you washing your hands, so they don't think that you are, or the nurses are. So if you add the H on the end of your AIDET, then you're also communicating it to them.
Yes, I love that. That's very creative. I love that. Maybe we should add one before the A as well. So we have AIDET, hand hygiene before and hand hygiene after.
AIDET. Yeah, hand hygiene in, hand hygiene out.
Right.
I like it.
I love that. That's clever.
That's a good reminder and a good mnemonic for that.
I love it.
Garrett loves mnemonics.
I do love mnemonics. It's because I've got a terrible memory, so I need whatever I can do to remember something is helpful. And I like what you touched on, Jill, that we're in there to educate and to provide kind of that second set of eyes. I know one of the challenges that new IPs, especially with device audits, you have to visualize the site. That means you may have kind of hands-on contact with the patient, or the nurse may, if you're working in tandem. But narrated care is, I think, something that's kind of like instilled to nurses over and over and over. And that may be a piece that as IP we're not as kind of accustomed to hearing about. So, Carole, what are some tips about narrated care and kind of narrating what you're doing that could be helpful?
What I've learned as a nurse, and I was trained decades ago, so what I've learned is, before you even touch the patient or move on to the next step of whatever activity you're doing in the room, tell them what you're doing. Some patients don't care. Well, as I was being trained as a nurse, you can tell there's a demographic based on age that trust healthcare professionals so much that they don't ask questions. But in our generation of, Gen Xers to Gen Alphas, we like to know what's going on. Tell people what you're doing. It doesn't matter what age they are. Just tell the patient what you're doing. I'm here to help the nurse who's going to do a stool collection for the specific specimen, the specific organism that we're testing for. Tell them what you're doing there. I'm here just to observe, to make sure we're all washing our hands and wearing gloves. Let them know. So they know that as we're going, I know what's the next step. Because you don't want to go and be like, okay, I will help the nurse maybe lift the patient's arm so we can get an axillary sample, and you just grab the patient's hand. That's violating their privacy, first of all. So yes, just every step, just let them know what's happening next.
No, that's great. That's great advice. And one thing that I also tell new IPs is, always ask the patient if it's okay. Tell the patient what you're doing, even if you think they're completely sedated. And sometimes you feel silly talking to somebody that you don't think can hear you. But I've always been under the impression that they can hear me, even if they're not signaling that they can, because newer IPs are sometimes very hesitant to go, check a Foley. That's very unnatural to somebody who's never been clinical before, to go look at somebody's Foley and pull up the bed sheet. So it's always best to say, hey, is it okay if I do this? And this is what I'm doing, because it's not super comfortable for either person, really. So sometimes just kind of walking through those steps kind of helps both of you.
Yes, I love that. And thanks for bringing that up. That's a great reminder. Always ask, because you are in their personal space. Ask them if it's okay. If they say no and want to know why, then that's when you take the next step and explain why. Because usually when someone asks why, it's because they don't trust you, or they don't really know what's the point. So if you're able to explain, then they understand the rationale, then they'll say, okay, I think I'm fine with that. Or they just say no, and you may have to come back at a later time.
Yeah. That's very true. And we don't as often get the brush off from patients, especially if, sometimes you'll see patients multiple times, but sometimes we do get a little bit of a brush off from nursing staff. And you may say, hey, can I round with you? And they're kind of Zoom, or they're kind of they're like, I'm charting. I'm okay. That's fine. So how do we maybe avoid the brush off? And if we do get it and we really do need to round with the nurse or provide some just in time education, how do we kind of encourage ourselves to get past that?
Well, if it's a bad time for them, it may just be a really bad time and you may not even get a yes, no matter what you say. So in some cases, it may just be, okay, it looks like this is not the right time, but I would really love to just shadow you. Some may say, okay, that'll be great. Because when you say shadow, they know that you're really here just to observe. You're not here to impose your presence. If they still insist that it's not a great time, you may just have to say, okay, what would be a better time for me to come back? Because I would really love to follow you around just to kind of learn about your processes. And I always say we need to position ourselves as, I'm here to learn about your unit. I'm here to learn from you. Especially when you do that Gemba walk, you're not there to tell people what they're supposed to do. You're there to just observe and learn from them. And they're usually more comfortable with it because they know I'm here to teach you.
I love it. That's very powerful advice. And use two terms that I really love, and I learned about them in the last couple of years, but they're really important. And that was the Hawthorne effect and then the Gemba walk. So if anybody's out there unfamiliar, like I was, what are those two concepts?
Yes, the Hawthorne effect is when people act differently because they know they're being observed. So they pretty much are, let's say you're doing a study of what's going on this ICU unit as an IP, you're not going to get the correct data because people know you're observing them. So they'll act a little differently. So they may, let's say it's hand hygiene. You may get 100% hand hygiene on that unit because they know the IP is observing. When in the normal day, when they don't know that you're observing and being a secret shopper, you may get the correct data that will show you that their compliance is really at 30%. So that's what the Hawthorne effect is. And that's why we love doing secret shopping, but secret shopping works mostly when it's champions on the unit just going by their normal day and collecting data by just visually just observing and then going to take notes later. And they don't, staff don't know that they're being observed. When you, the IP, come there, it's really hard to be a secret shopper. The Gemba walk is really when you go to learn about the team and how they operate on the day-to-day basis. So just learning about their daily operations, observing, taking notes, and learning from them. And usually with the Gemba walk as an IP, you learn a lot about a unit. Let's say you decide, I'm going to this IC unit every Wednesday for 3 months. You learn so much about that unit. You'll know how they operate. You'll know if they have a relationship with IPC or not. You know if they like you or if they don't like you. And you'll know what they're compliant with and what they're not, and what trends you notice and what may need to be changed if we need to start a quality improvement project on this unit because of this specific non-compliance issue. Let's say was the simple thing, hand hygiene, for example.
And Gemba, just for those learning, is a lean term that means where the work is done. So when you're doing a Gemba walk, you're going where the work is done and you're observing the work. And so it can be super helpful just observing. And like Carole said, you're not auditing anything, you're not marking things down, you're literally just watching how the work is done, where it's actually done.
I like that. That's very, very important because if the only time people see us is when they might get in trouble or, it's for a compliance thing, their response is going to be really different. So, Carole, as we kind of close out this, we've talked mostly about patient-facing and frontline nurse, but as we close out, can you give us some advice and go-and-dos for the audience about interacting with nurse leadership, whether that's the charge nurse or the RN supervisor, and things that they can do to build that relationship?
What I've learned in my experience is the charge nurse is a very good person to become your ally as the IP. when you get on the unit, usually recommend when you go for rounding, instead of just picking one of the frontline nurses. In general, they're very busy anyways. As for the charge nurse may be the one at the desk that day just picking up phone calls, but at least it gives you access to one of the leaders on the unit already. Once you get to build that relationship with the nurse, the charge nurse, the nurse manager is really easy to. My recommendation is always start with the charge nurse, go up the line to the nurse manager, then the nurse director, because it's easier to start from the bottom and start going up. Sometimes the nurse director may be very inaccessible, or the nurse manager may be in meetings multiple times a day, and you may not even need her for day-to-day operations, because if you get there, you observe something, the charge nurse is on the unit, so she'll be able to answer questions right away. You may have to reach out to the nurse manager if, let's say, you're dealing with an outbreak on that unit and you want the nurse manager's support to help you ensure that staff are following hand hygiene practices, cleaning and disinfection correctly, because we have an outbreak, we're trying to contain it. But yeah, by starting with the charge nurse, you're already a foot in the door.
That's excellent takeaways and really concrete things that, any IP out there can go and start building those relationships, start developing those relationships with frontline nursing. Carole, I want to thank you and for your insight and expertise, and then really breaking down some of these. They're soft skills, but they're also really important to our job. So thank you for your insights today.
Thank
you so much for having me.
Well, that was a really great conversation with Carole, and she has so many awesome points that she uses. As you can tell, she has so much experience in this. I think she said 15 years in this type of a role. I love that she said you have to start a relationship first. That's one of my own kind of personal things that I always say too, that you have to start the relationship, and then some of the other things just kind of naturally fall into place. If you have a good relationship with people on the units you're going to, then if you have to give feedback or say, we really need to work on our hand hygiene or our isolation compliance, it's so much easier once you've already developed that relationship. And of course, I loved how she talked about the AIDET framework. If you're lost, you're not sure how to start up conversations or even talk to some of these clinicians, it's always good to have a kind of a structure behind how you go in and start those conversations, or just start talking in general as a newer IP. So I love the AIDET framework. If you're not sure how to do that, then just Google it and start trying it out and see how it works for you, because it really can be a very powerful tool and can be really helpful to you.
I agree. That was there's a ton of great takeaways from this episode, but that AIDET framework is a huge one. If IPs are not getting the support or the conversation with frontline staff that they're hoping to get, I think implementing that AIDET framework, hugely helpful. I also think it just humanizes us. Carole touched a lot on, it's a human to human conversation and an interaction. And that framework can help, IP be more humanized, and then also treat, frontline nursing with, the respect and expertise that they're definitely owed. So if you haven't heard of that, go out and Google it. I will be learning more about it after this episode wraps. For our transmission control audience, thank you for joining us. And remember, infection stops where information starts.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.